Hey, good morning, everybody. Welcome to Alabama EMS Challenge. We've got Dr. Knight with us. First is going to give us a lecture on ECMO and EPCR. We appreciate you joining us. As always, I'll be listing a link in the Q&A section for an attendance form. You can click on that, fill out your attendance form. During the breaks, we'll also have a slideshow showing that has a QR code that you can scan to get the attendance form. And if all that fails, you can send an email to alabamaemschallenge@gmail.com and you'll get an automated response with a link to the form. Please fill out a form even if you don't need the CEU so that we can record your attendance. And thank you for being here, Dr. Knight.
Hey, so can you hear me is the microphone working? Okay, cool. Yeah, as you said, I'm Steve Knight. I'm one of the ER docs at UAB. I'm also the physician lead for our department for ED ECMO and kind of help build the ECPR program. So this is something I'm really passionate about. So I'm really happy about the opportunity to come talk to you guys about this because I think this is a huge deal that we're starting, and it's kind of starting all over the world that's going to make a big difference. So these are our basic objectives. I mean, basically, we're going to talk about ECMO. We're going to talk about particularly how it relates to cardiac arrest, kind of the reasons why we're doing it and why what's so promising about it, and then how it relates to what's going on worldwide as well as locally in Alabama. Please stop me at any point to ask questions. I'm more than happy to answer anything. I'm kind of a fast talker, so I'm going to try to slow it down a little bit as well and not try to just rush through it. But if you have any questions as we go along, please stop me. I have no disclosures. So as I said, this is something that's tremendously exciting. I think this is going to be an absolute game changer for cardiac arrest. It's something that's kind of been going on for over a decade now, but it's just slowly starting to build up steam. And I think, the amount of impact that this can have on the outcomes of cardiac arrest is just huge. And so, like, I'm super pumped about it. Obviously, and I want to get you guys excited about it too, because obviously y'all are one of the biggest parts, are instrumental in the management of cardiac arrest and in all aspects of cardiac arrest care, including this aspect. And so I want y'all to be just as excited about this as I am. So to start with, kind of the reason why this is important. So this number, 7.5%, that is the national average for neurologically intact survival from cardiac arrest. This is from the CARES database from 2022. So I don't know if they've released last year's yet or not, but the most recent data I can find, still, despite everything we do, everything that y'all do pre-hospital, everything we do in the hospital, all of the millions and millions of dollars of research and things that have tried to improve these outcomes, still 7.5% are able to have neurologically, an intact survival. Unfortunately, in Alabama, we're also probably below that. And there's a lot of factors for that. But when we've looked at our own internal data and some state data, that the numbers are actually even worse than the rest of the country. And a lot of that, is related to our baseline population, a lot of comorbidities that are in this region. Also, our bystander CPR rates are just in the toilet. And for whatever reason, it's when you compare us to like somewhere like Seattle where they have really good bystander CPR rates, even if you look at the national average, we're way below, and that's a huge aspect of this. And of course, we don't really have the AED availability that some other places have, and so those things are not as easy to fix. There are other people that are working on actively trying to fix those problems in our area, but in the end, that's kind of beyond our actual control right now. And actually, when you think about it, and when we talk about when we cannulate people for ECMO and when we do this is, the 30-minute mark of someone's cardiac arrest. This is at the point, and sometimes even beyond that time. This is the point where you're going to call it, right? You're thinking about the decision tree right here is, I'm either going to put them on this therapy or I'm going to pronounce them dead. And so really, we're talking about a situation where a person has nearly 100% mortality. And instead, if you happen to be in Minnesota, where they've turned this into an art form, their neurologically intact survival is 43%. Almost 50% of their patients that they cannulate walk out of the hospital with little to no neurologic disability whatsoever. So I don't know of anything that in my career that's had this much of an effect. The other thing to think about is a lot of the work that we do, I did a lot of stuff with hypothermia, and there's a lot of stuff that a lot of the efforts that we do are related to the people that we get back, to that 27% that we get that we get ROSC on. But the other 73%, that's what we're actually targeting. That's a huge population of people that are otherwise not gonna survive. So to kind of back up a little bit, that's why it's important, but what actually is it? So we'll kind of talk about what ECMO is in general. So the basic principle of it is you're putting a patient on temporary heart and lung complete bypass. You are pulling blood out of their central venous system. You are putting it through an artificial lung oxygenator and pumping it back into their body. There's two different forms. There's VV ECMO, where you're putting it back into their venous system. So at that point, you're only doing a pulmonary lung you're only bypassing the lungs. And then there's VA ECMO, where you are doing the work of their heart and their lungs, and you're pushing it back at pressure and giving them an actual blood pressure based with this pump. The main reasons that it was developed and the primary uses for ECMO still right now are for cardiac surgery. So if someone undergoes open heart surgery where they go on pump, and they need to have complex things done with the heart stopped, then they put them on ECMO. It's also had some significant use over the last couple of decades in people who develop severe respiratory collapse or cardiogenic shock. So whenever we have a really bad flu pandemic, this has had there's been a spike in the use of ECMO, and we used it for it was used for their one kind of the OG COVID when a bunch of people were going into respiratory failure. If someone kind of just fails every other technique, then we can put them on ECMO. And a lot of times for respiratory failure, you're doing the VV ECMO. For cardiogenic shock, it's kind of it's a bridge to some to definitive therapy for them. And so that's kind of where this primarily lives and where this all bore from. Just to kind of take it back a little bit further to talk about kind of where this started, because I think this is really interesting. So this guy who looks like a mad scientist, or like someone who maybe is dressed up as a mad scientist for Halloween, his name's Sewalt Nolay. He's actually a really famous cardiac surgeon and from the 1950s. And he did a lot of things. He developed a lot of processes for cardiac surgery. He also pioneered a lot of the use of hypothermia during surgery, as well as he was instrumental in building the first pacemaker. So he was trying to figure out how to do surgery on kids with congenital heart defects. And at this point, this was something that was kind of universally, with these defects, it was universally, deadly. These kids would not survive past a certain age. But you can't do these surgeries on a beating heart. So what he did was he developed a process where he connected the parent's femoral vasculature to the central vasculature of the child. And he performed surgery on the kids with their heart stopped, with the parent perfusing their body. This was the 1950s. You could never get away with doing something like that right now. But pretty out there idea. And for a surgery that was universally, non-survivable, out of 45 kids, he had 28 kids who survived that process. And so that was kind of the groundbreaking thing that led to someone saying, well, let's actually make a machine that does this. And from there, this was developed and kind of went, obviously advanced from there. And so it's not necessarily the most complicated system in the world. It's literally just a pump and an oxygenator, and then the cannulas to work it, or to access the body. So the cannulas are gigantic. They are, think chest tube. They're 21 to 25 French in size. You're putting a garden hose in somebody, and it's 60 centimeters long. So these are not, that probably the biggest factor for the limiting factor for doing this therapy is being able to get these in, because it's a very difficult, it's not very, I wouldn't say it's a very difficult procedure, but it's one that is more challenging to do, especially in without resources. They've got these big wire reinforcements in them because if you think about the pressures that these are generating, that's kind of why they need that. Then we have the pump itself. And so the pump, I think what's just kind of interesting about it is a centrifugal pump. And what makes that interesting is that it works a lot like a heart. It's afterload and preload sensitive. You have to, it vasopressors and things like that affect the pump itself. And then probably the biggest part of this is the membrane lung. And the kind of the way it works is you've got these little tiny microporous little tubules inside of this lung. And so you've got blood kind of crossing over these tubules. Inside, you have gas going one way, and which is doing the oxygenation, doing the ventilation, and then you've got water that's doing the temperature control. These things are incredibly efficient. Like in my mind, I would think, okay, so you've got this little thing that's about this, the size of, I don't know, I don't know what to compare it to, but it's about, well, that big, about the size of 5 Dexicards or something. I would think that if I'm doing the work of 2 lungs with something that size, I would be flush rate with the oxygen, trying to pour it in. But these things require 2 to 3 liters per minute. That's all that is required to result in the gas exchange for someone's entire body. And so that's ECMO. If we incorporate it into cardiac arrest, there's kind of 2 different terms to use. It's extracorporeal cardiopulmonary resuscitation, or ECPR, is the most common thing that you see, and then ECLS, or extracorporeal cardiac life support. So kind of talk about kind of what it does and what it doesn't do. And so kind of the best way to think about this is a bridge. This is not a definitive therapy. It is not bringing someone technically, you're not bringing someone back from the dead. You are bridging them to definitive care. And so, essentially what we're trying to do when we put someone on ECMO, we kind of put everything on standby, right? We perfuse their body again, we perfuse their brain, we perfuse their heart, and we allow time to be able to fix what caused them to arrest in the first place. So if they had a massive PE, if they had, a coronary occlusion, if they had whatever it is that caused it, a lot of these things take longer than 20 minutes to fix, but by that point you've lost their brain. And so this allows us to have someone on the support. They can be on it for days, depending on what it is that caused the problem, and bridge them to to definitive care. It does actually, interestingly, reverse the circulation in someone, because you're pulling it out of their veins, you're pushing it into their arteries, into their aorta, and so they actually get reversal of flow in their body. But it's not a cure for cardiac arrest. We're not going to fix the problem. Sometimes you can have someone, if let's say it was a blood flow to coronary arteries issue. Well, if I'm pumping a lot of blood into your coronary arteries, that's oxygenated and everything, sometimes we can get somebody to come back with that. But in the end, we're not trying to fix the problem. And the most important thing is you can't fix a dead brain. So if you've lost that, if someone has an anoxic brain injury, then there's no amount of therapy that's going to fix that problem. So briefly to kind of talk about the research, because don't trust me at my word about those numbers. This is kind of, this is what's been done to prove that kind of this is something we should be doing. So this is the arrest trial. This is the biggest, kind of the big one that that has caused a lot of the waves in terms of ECPR in our country, because this is the first time that someone's done a randomized control trial on ECPR in the United States. And so basically what happened was people got to the hospital and they got randomized. They either bypassed the ER completely and went straight to the cath lab, where they got cannulated and they got a heart cath as well right then. And so they were put on ECMO and they were admitted upstairs. Or we did the normal thing, right? They go to the resus bay, they get good, high quality ACLS. Regardless of which direction you went, everyone kind of got the same care after that. Everyone who they got back got the same care after that, including if someone needed a heart cath, they got a heart cath. They needed, whatever, they would get all the same therapy, but it was just kind of which direction they went when they went in the hospital. This study actually had to be stopped early. So they only ended up getting they only enrolled 30 patients, because when they did the initial analysis of the data, they realized that there was such a wide improvement on the patients that got ECPR that it was no longer ethical to continue doing ACLS. Just crazy. The NIH stopped this study because they couldn't ethically continue doing what we're doing everywhere in the country. And so their initial results, they had 43% neurologically intact survival, compared to the 1% on the or 1 person on the ACLS side. That person ultimately didn't survive past 3 months as well. Also, interestingly, one of the people on the ECMO arm actually refused to be included in the study once he woke up, which meant he was probably neurologically intact when he woke up. And talking to them and hearing from them, their internal data is probably, maybe even better than this. Now, this is a place where they had it kind of down to an art. Like I said, this is a different system. when you look at other places that are doing this in the country and around the world, 30 to 50%, it seems to be the average. Most people around in the mid 30s would be, an expectable survival from this, which again is still way better than what we would otherwise see. So one other study to talk about, this is called the hyperinvasive trial. This was in Prague. They randomized on the scene, and patients would either get standard or this hyperinvasive kind of bundle therapy where they would get a Lucas on them. They would actually get the kind of started on cooling and pre-hospital with cool fluids, and then they would get cannulated immediately on arrival to the hospital. Their numbers were closer to the 30s. If you're randomizing people on the scene, but then cannulating them 15, 20 minutes later, a number of those people are going to come back. And there's going to be some people who are in the ECMO arm that don't get ECMO. There's going to be people on the ACLS arm that, for whatever reason, get ECMO. So there was a fair amount of that, and some. And the other thing that they talk about in this study was the fact that it's really hard to know what someone's neurologically intact is for post-arrest, because a lot of people will also be really weak if they've been in the ICU for weeks and that kind of thing. And so, but anyway, still in my mind, an impressive study, and one that kind of further supports this. So moving on to kind of so how does this work? How do we kind of feasibly make this work from a systems standpoint? And there are various places in various parts of the world that are doing it very differently. And so, kind of talking about the Minnesota people again, that we kind of talked about what they do, and this is a busy. And so, that's very much the fastest way that anyone's been able to do this. And they have all the equipment and all the tools. They can get these cannulas in super fast. I mean, they have videos of them putting this in 4 minutes, when in many situations this takes like 15 minutes to put in. The problem is, or the reason they're able to do this is they have 2 cardiologists who have just decided they don't need personal lives. And so, these people have dedicated their lives to this, but you're not going to get that, around everywhere. And so, that's just because from a resource standpoint, it's not necessarily feasible in a lot of systems. There's another approach that I'm calling the San Diego approach, because they're the ones that are kind of teaching this. But they've essentially credentialed every ER doctor in this one system in San Diego to know how to do this. And they'd use 2 EM physicians to do this. One is the kind of the medical team leader, who's going to receive the report from EMS, who's going to manage the medical side of the cardiac arrest, and then there's someone else whose only job is doing the cannulation. And that is something that is this is something that's definitely much more feasible from a resource standpoint. They haven't published their data to know if this is, from an outcome standpoint, kind of how that looks. But there are a lot of places that are doing something similar to that. So I'm here to talk about the pre-hospital stuff, right? I'm here to talk about the pre-hospital considerations, and the biggest one, and the biggest dilemma that probably a lot of you have already thought about is, is that when do we transport? Because with good reason, stay and play is kind of the name of the game, and there is good data to support ROSC and outcomes if you are running the code completely on the scene, and so if you fully recognizing the fact that it's very hard to do high quality ACLS in a moving ambulance. And so, if you leave too early, if you don't give the patient a chance for ROSC in the field, then you're missing that opportunity as well. If you leave too late, well, after a certain point, and that's not a long point, we can't do this anymore because of the risk of anoxic brain injury. So this has been looked at in a lot of different places to try to figure out what's the optimal time, and how what should we be saying is the right opportunity to to consider. All right, this is not working on the scene. We need to move. And so part of that is looking at what's our probability of survival, as time goes by, and we know that precipitously drops. And so after 10 minutes, it starts. You have kind of fastest drop. After 20 minutes, you're really kind of getting to a point, and especially 30 minutes, you're approaching a 0 chance of survival. Certainly, this was a big study they did of looking at pre-hospital codes and chance of survival based on kind of time, and they found like kind of similar times, and for what it's worth on that study, they're what they recommended was like 16 minutes was where they thought that was kind of the branch point there. A lot of the systems are recommending 2-3 rounds, and if you're not having support, you're not getting anything, you're not getting anywhere, then to consider, especially if it's a candidate to move. Also, who do we transport, right? We've got 2 very different people here on these pictures that, one of them very much could be a ECLS candidate, the other one maybe not so much, so, and I know that you guys see enough of these to have the same gestalt. You walk in, if you're running a nursing home code and it's fairly evident that this person's probably arrested 6 hours ago and no one noticed it, or you've got someone who's got multiple comorbidities. These are not people that are going to have any meaningful benefit from something like this. It is extremely resource intensive and also still requires a lot of strong body to be able to overcome. But you have the person who was the middle-aged person who was working and suddenly goes down from VFib arrest, has witnessed arrest at work, or you have all the these people that you're like, you look at them and you're like, this person's not supposed to die today. That's the person that, like, when I want you in your mind, you think that's the person I need to be thinking about. And so these are the general, I'm not, before we talk about anything specific characteristics, these are the general things to just kind of in your mind to be thinking about. This might be someone that we want to consider it if you're in a system, obviously, that has this capability. But I want to impress upon y'all that this is, if you're somewhere that doesn't have that, this might still be coming in the sometime in the future, and it's not something that's necessarily limited to academic centers. There are a lot of community hospitals and a lot of places you may not expect to be doing ECMO that are doing this, and in some ways it's actually easier to develop one of these programs in a non-academic center than it is in an academic center. And so anyway, someone who was generally a previously healthy person, right? Maybe they have high blood pressure, maybe they have diabetes, but they're not in renal failure. They had kind of probably the most important thing is good characteristics of their arrest, which locally is going to be probably one of our biggest limiting factors. So it needs to be a witnessed arrest with bystander CPR. They need to have little to no flow time, and pretty good low flow time. It doesn't have to be a shockable rhythm. We know from lots of different realms of research that obviously the shockable rhythms are the ones that are more likely to have good outcomes. And so a lot of times these type of therapies will start with only shockable rhythms, but that's not the case. So certainly someone who's in persistent VFib, that is someone who still has good function, still has enough perfusion to be in VFib, and that means they probably have perfusion. They might have perfusion of their brain. That's someone to think about. But also PEA, because you think about things like massive PEs. Heart's probably dead, which means their brain's probably dead. So I wouldn't necessarily consider it in that population. And then of course, if someone's having intermittent ROSC or intermittent signs of life, if you can't maintain the ROSC but you're getting it, then that's a perfect person to have on ECMO, because we can stop them intermittently arresting and fix the problem. And then if based on your own history, you think, well, this is something that's fixable, but that I can't fix. If someone's got a massive PE, they need a thrombectomy. If they've got a STEMI, they need to go to the cath lab. And so, and all the epi in the world isn't necessarily going to fix that. And so, if based on the story, you're like, this might be someone that we can reverse, I would strongly consider, thinking about moving that patient. And so, I'm here to talk about the information. I'm not here to give you guys, advice on what to do. This is, I'm not obviously leading any protocols. You follow your local protocols, especially depending on what kind of capabilities are in the area. I certainly would not advocate not trying at least 2 rounds in the field, or would even in a patient who would be a really good candidate. Like in any situation, that would be, you would still at least do that. Obviously, in many situations, you're going to do a lot more than that. if the decision is made that you're going to try that this person might be an ECMO candidate, the biggest thing is maintaining perfusion. Like you want that brain to be as perfused as possible while you're transporting. And so mechanical CPR would be the best way to maintain that, and then, it wouldn't be a bad idea to say, hey, by the way, when you're calling this in, this person might be an ECMO candidate. This is not a thing here. This is not a thing in, really most places right now, but there's suggestion that, could there be a cardiac arrest receiving center in the same way that there's a trauma receiving center, right? The only place where I know that they're actually even kind of, well, there are a few places where they're kind of doing this. So you think about, so San Diego actually has done that, where they've credentialed, they've kind of created this network of hospitals where the capability exists. And it's actually written into their protocols that if for these patients that they actually would bypass a hospital and go to one of those places. Los Angeles has done something like that, but we also don't know how that's going to work from an outcomes point. And so this is not something we're doing here, or that is in the even in the near future, but it's something that kind of to think about. Another thing that's kind of out there that some places are doing is kind of you have a community hospital. Maybe the someone who can cannulate rushes over there and does the cannulation, meets them at that center, and then the patient moves from there. But again, we don't know the outcomes of that kind of thing. What about in the field? Why don't we come to you rather than you coming to us, right? Well, that's actually already been going on. And so the Paris EMS system, the Paris ECMO team, has been doing this for over a decade. And so this is they're doing a cannulation in the Louvre. There's other pictures of them doing this, like in the subway. They actually have a team that they deploy for these cardiac arrests and go and they do a little bit of a different technique to access, but they do this in the field and then transport the patient. And their outcomes are also very good. In the States, this is also, there are places that are starting to do this. So in Minnesota, they've developed this, I think they call it the ECMobile. But it's a separate rig that goes and meets the ALS unit in the field. This thing is ridiculous. It's got like a little mini cath lab inside of it. It's, again, you've got these cardiologists that are doing this, and so, somewhat of an excessive thing that may not be reproducible, but it's very interesting. It'll be very interesting to see kind of what they're able to do with it. And then a lot of other agencies are doing similar things. So this is in Albuquerque. They've had this for like 5 years or so. And this is not that different from a standard rig, other than they have an ultrasound in there, and then they obviously have the supplies. And so similarly, there's going to be an ALS unit that's dispatched, and then they're going to meet that unit if this is a patient that would meet criteria. They were able to decrease their cannulation times by like 30 minutes by doing this, which is huge because time is everything in this case. And so they're doing this. It's being done in San Antonio. There's a few places around, where they're kind of moving to a pre-hospital, which, let's see as well. So where are we here in Alabama? So right now, to my knowledge, now I could be wrong about this, but to my knowledge, and based on kind of there's a registry, a national registry for ECMO, and so based on the ELSO, which is what's called the registry, UAB is doing it. Children's has a very big ECMO program. Princeton is listed on ELSO as it says limited ECMO capacity. I don't know what that means. My guess would be that they're doing it intraoperatively, but they, I guess, have the capacity. And then this is not listed in ELSO, but I know via word of mouth from people that work there that there's a guy in Montgomery that's just doing this as well. There's an ER doctor who's just doing ECMO cannulations in the ED. I don't know a whole lot of details about that, other than the fact that that is something that is occurring intermittently down there. Outside of those places, they're not, to my knowledge, again, I could be wrong. I don't know if this is, and if anybody is here from the south of the state, if this is being done in Mobile, I would love to know. I know that like Florida Panhandle, very close, has very strong, big ECMO programs. But, again, even places where this isn't being done yet, I think that there's growing compelling evidence that might, create more of these opportunities. And so we're in Birmingham. I'm in Birmingham. I wanted to talk a little bit to people who are, specifically for the Birmingham EMS providers, because we do have this capability right now. So this is our current inclusion criteria. Sorry about the purple and gold. I am did go to LSU, so go Tigers, but I did not realize that. So these are our criteria right now. They're, I will admit, very strict right now, because essentially we need to, we need this to work so that we can expand it. And so our age cutoff is 65. Some places, a lot of places are using an age cutoff of 65. Some are using 75. And then kind of the blanket not baseline sick. So that, but to that in specifics, that means end-stage renal disease, end-stage liver disease, things that are, if someone is just like has a bad, it has significant chronic illness or significant neurologic disability, then that's not someone that's going to be a good candidate. And then uncontrollable bleeding except for the fact that there's some use for this in trauma as well. And then for our arrest characteristics, which are going to be our biggest limiting factor right now until we can expand our criteria. So like I said, no flow time, essentially. They need to have a witnessed arrest with immediate CPR. And then our cutoff for total arrest time at the current time is 20 minutes, which is tough, right? A lot of places are doing 30 minutes. And I think that we're gonna move it up to 30 minutes, but right now it's at 20 minutes. But looking at our data, this actually, surprisingly, that's not that uncommon, to be honest with you, is getting in around the 20-minute mark. But that definitely certainly is going to be a limiter. And then, like I said, asystole is a poor prognostic indicator, and that probably, if someone's in asystole, they probably don't have brain function. That would be pre-hospital too, but that's still with that 20-minute cutoff. But yes, so the best example of that one happened, actually not that long ago, was a patient that arrested en route. That would be a super common thing, that that person had obviously a witnessed arrest with excellent, CPR, immediate CPR. And so those would be our biggest, that's probably going to be the bigger people that get included right now. But if there's a good candidate that arrests at home but has good characteristics, that would be someone who would also be considered. And so again, follow your protocols, follow the usual protocols, but have it in the back of your mind. And if you have someone that you're like, this might be someone that we could help, consider the early transport, especially if you're not seeing a lot of effect from the ACLS. Maximize perfusion. If all the oxygen in the world to their lungs isn't going to fix if the blood isn't flowing. So the perfusion needs to be maintained, and to try to maintain the heart. Maintain the brain. And then, of course, continuing high quality ACLS. Those are my references. That's my email. Please contact me. I'm also easily contactable through FERG. If you have any questions, if you want to learn more, or if you have any concerns, or if you want, obviously, there's a lot of things I don't know about all the things that y'all do, and so I would love to learn, more about that too, and how we can best tailor this to best help our population.
Hey, thanks, Dr. Knight. We actually got a flurry of communication, because I think a lot of things are kind of convoluted. It's a controversial topic to some degree.
Sure.
So try to unpack a few things. So one, for all the EMS providers, whether or not we start resuscitation or don't start resuscitation doesn't have anything to do with the ECMO criteria that Dr. Knight showed. That's regulated by the state operational guidelines. It's pretty straightforward. And of course, we're not going to base that on any prior knowledge or assumed prior knowledge of downtime or pre-existing conditions. Two, we've got a lot of high performing agencies in the area, most of which through CARES data are showing average time of ROSC around the 30-minute mark with high neurological outcomes, CPC1 predominant outcomes. So that's curious that the criteria is under 20 minutes. So I know you mentioned that that might be expanded, but yeah, it seems to me if the average is at 30 minutes to ROSC on patients that survive of on the scene time, I just don't want people to get the message that they should get off the scene quickly because you know you mentioned the Grenoble study, which I think was 2020, which is looked at time on the scene, and the primary metric there was over 25 minutes on the scene or under 25 minutes, with a huge delta in outcomes, over 12% survival when over 25 minutes on the scene, under 2% when under 25 minutes on the scene. So it was a big sample size, well-constructed study that's pretty recent. I think that's what we've seen in the local CARES data as well, is that when we just jump and transport the medical cardiac arrest patients immediately, the outcomes are pretty bad. So I guess there's a balancing act, right? When can we get them to ECMO versus getting ROSC? And I think the answer has to be we have to concentrate on ROSC, right?
Yeah, no, I mean, I agree with you, and I hope that I'm not, yeah, like I don't want to encourage anyone to, you know, like that the cutoff right now is 20 minutes is not because we don't think someone could come back at 30 minutes. It's because we know that if if we don't get that process started early, then we don't have a potential for benefit there. And I think so a standard time is 30 minutes for initiation of ECMO, and I think that's because the program is still developing and we need to have, I mean, essentially, you know, you need good outcomes to be able to convince the hospital that like we can keep doing this. And the more people you include, the more bad outcomes and more, you know, more people you have the potential to save, but also the more bad outcomes that you're going to have. And so this is partly a balancing act of, you know, being able to develop the program. And so that's why the criteria are strict right now, but it's not because I don't think someone could come back at 30 minutes. I do think the longer time goes, depending on the characteristics of the arrest, the risk or the likelihood of neurologic recovery, you know, precipitously drops. And so.
Yeah, so the other confusing point there is the issue of asystole, because historically, years ago, we used not to even attempt resuscitation on patient with asystoles. But the CARES data has actually shown us in local agencies that we're resuscitating more patients who start off in asystole than we are patients who start off in shockable arrest, because there's so many more of them. The rate is lower, but the actual number of survivors is extremely higher by factors of about 4 or 5. So don't equate asystole with unsurvivable, because that would cut out probably 2/3 of the cardiac arrest survivals in the central Alabama area.
Yeah. Well, and this is not who to attempt resuscitation on either. Right. This is not. I'm not talking about who gets resuscitation versus who doesn't. It's more, you know, there are tighter criteria for this resource intensive therapy. And you know, I guess the question also would be, how many times is a systole actually find VFib that's so, you know, that we can't even detect on, you know, on the monitor, that we can't see it very well.
Or how many patients are actually resuscitated from PEA and asystole who we previously theoretically thought weren't possible, and their theory might have been wrong. Yeah. So I'm excited about the idea of resuscitation centers in this area, especially that utilize ECMO. I think that's successfully been done, as you pointed out, in other places in the world. Tokyo is an interesting system that we've heard about in the past. But as it currently stands, for example, at UAB, will the cath lab take patients who come in cardiac arrest?
So we are doing it in the resus bay.
You're doing
in the ER.
Okay.
And it would be 24/7.
Okay, so you're doing ECMO in the ED.
Yes. ECMO. Then I mean, it would certainly be up to the cardiologist on call, but that would be an expectation. An expectation of doing this therapy is that if there's a definitive treatment, that they would go for it. So if something is found if they need a thrombectomy, if they need a PCI, you know, you're not going to do that on someone who doesn't have is pulseless and not on ECMO. But the ways that they're doing it, you know, in a lot of these places is you get them on, you get the perfusion back, and then most of these protocols involve immediate PCI. But obviously I can't force the cardiologist to do something, and it would depend on who it is, but that is the expectation, I would say.
Yeah, I'm mostly focused on decision making on the scene.
Mhm.
So one of the things you mentioned was, hey, persistent VFib, VTAC, understand that those patients can benefit from intra or peri-arrest PCI, right, or point lysing even.
Mhm.
I just don't know that anybody's ramped up. The piece of the puzzle that I don't have is what hospitals will actually consider that if we bring a patient in cardiac arrest. If we make the decision to leave the scene early because we think it's persistent VFib that can benefit from that, are there any hospitals we can transport to that will actually do that?
Well, I don't know that anyone's going to do it on someone who doesn't have a pulse. So like intra arrest, like meaning that they have nothing perfusing them. Like I don't know anywhere where they're doing PCI on those patients.
They're doing simultaneous ECMO and PCI in the
Yeah,
Tokyo
ECMO,
system
but
and in the Prague system.
yeah, so ECMO PCI, but like in someone who's already like who's arrested and doesn't have a means of being perfused. So if they're on ECMO, then they're being perfused, and then they can get immediate PCI. And so, but yeah, the piece of that puzzle would be that they have to be on ECMO. Otherwise, you can't get into the cath lab unless you have something perfusing.
Gotcha. Yep. So really our decision from a pre-hospital perspective would be to focus on getting ROSC in the field, right?
Yeah. I mean, my focus would be continue to do what you're doing, do the high quality, CPR and ACLS that you're doing. If you have someone who's in persistent VFib, also, giving them antiarrhythmics and doing all the things that are per protocol and that have good, effect. But I guess what I would say is if you have someone who you think might also benefit from this therapy, that this should be, I would consider this. And we're going to make this more of a, this is going to develop further, and this is going to be something that, we can expand the criteria, but also just expand the use of, and hopefully have really good effect from. That would be, yeah, really important to know. Because if someone was down for any period of time without bystander CPR, then they probably wouldn't be someone who would be qualified. Mm-hmm. Yeah, and that's going to be locally a limiting factor. Looking at our CARES data, looking at the ROC data, the bystander CPR rates, just aren't great.
Yeah. So for those online, the conversation is how important does it become to determine downtime? And that will be important in the way the system's currently heading and what Dr. Knight's speaking about. The problem I would see with that is that information has been proven time and time again to be utterly inaccurate and unreliable. It's not even really a metric that you can make any decisions on because bystanders experience both time constriction and time dilation in times of high stress. And another thing that happens is they say, the patient has no obvious signs of death like rigor or lividity, and the bystander says, well, last time we saw him was dinner last night. That doesn't mean they've been in cardiac arrest since dinner. If they don't have lividity or rigor, then we know that hasn't, but that really deflates the expectations of the crew to have that conversation on the scene.
Yep.
So
that's true. I mean, but at the same time, when you compare it to things like strokes, if someone has a wake up stroke, we can't say that their stroke started when they woke up. And so we have to use our consideration of if we're giving them thrombolytics based on when we know it could have started, the longest we could know that it could have started.
Yep, that's true. I would suggest that the difference in communication accuracy is wildly different between being on the scene with a suspected stroke patient and being on the scene with a patient who's in cardiac arrest.
Sure. Yeah, I can see that.
So very interesting stuff, exciting stuff. Hopefully this progresses in the Birmingham area. I hope that we evolve into some type of a resuscitation center to improve our numbers. And any other questions in the room for Dr. Knight? All right. Well, we're going to take about a 10-minute break. and we're going to come back with Dr. Kirby. He'll be talking about pelvic and lower extremity trauma. Hey, everybody, we're going to get started back. I'd like to welcome Dr. Kirby from UAB. He's going to be giving us a lecture today on pelvic and extremity trauma. I'm proud to have him. So, Dr. Kirby, take it away.
All right. Hopefully everyone can hear me. I'm excited to be here again. My name is Paul Kirby. If you see me out, I'll respond to Paul, Kirby, Dr. Kirby, hey you. I'll respond to just about anything. I don't get upset about those things. But I'm presenting today on pelvic and extremity trauma. Financial disclosure, this is my favorite slide because I have none right now. Maybe big tourniquet or big pelvic binder or sponsor me one day to give a presentation like this, but not today. So I'm not getting paid for this. I thought it was important to share a little bit about me, especially since I'll be working with a lot of you over the next couple of years. So again, my name's Paul from Nashville, Tennessee originally. Grew up playing all kinds of sports. My dad worked at UPS. My mom worked at a church. I have two younger sisters. After high school, I was fortunate enough to play college baseball. I went to junior college for 2 years, went to the Junior College World Series there, and then transferred to Division II school up in East Tennessee, Carson Newman University. I see a lot of similarities between my college athletics and what I see around here in the fire department and with EMS. A lot of discipline, respect, different things you learn that'll take you far in life. Pictured with me, here's my now wife. We've been dating since 15 years old. I think we took a break for a week, and during that week break, we saw each other 3 or 4 times, so I don't even think it counts. But I found someone to put up with me, and my joke is I couldn't let her go. It's been pretty cool. We've grown up together, went through the highs and lows. She's definitely a lot cooler than me. If it was up to me, I'd sit on the couch and watch sports all day, but she keeps me active, going out and do things. Got into med school in 2018. And as you would expect from this picture, you would think I just flew through and it went great, but it didn't. So COVID hit, we went on lockdown and I had to study for my first board exam, and I tried to look as homeless as possible during it. I locked myself in the basement, painted the walls, hung up everything, and did the best I could. But it wasn't all that bad. I got to do a lot of cool things up in East Tennessee, a lot of hiking, a lot of snow. So that's a snowman. I don't know if y'all get enough snow down here in Alabama. So far, it's a little too hot. That's my dog, Oakley. That's some pictures I took up on a mountain. And then I got to go to the Bristol race up in East Tennessee, which was incredible. Brought tears to my eyes. The Start Your Engines, the fly over the national anthem. It's awesome. It's incredible. I'm excited for Talladega this year. I have a couple more pictures sprinkled throughout just to kind of break this up a little bit. So some of the objectives we're going to go through pelvic trauma. We're going to talk about the anatomy, some classifications of injuries. We'll talk about a physical exam maneuver you can do out in the field, talk about pelvic binder, sacral fractures, and acetabular fractures. And then we're going to go through extremity traumas. By no means is it going to be all inclusive. I'm just going to kind of hit some points, some things you can look out for on the field. We'll start with the upper extremity, lower extremity. We'll talk about tourniquets. And then I went back and looked through some of the guidelines that we have here in Alabama. First and foremost, whenever you arrive on a scene and trauma situation, you're going to do your primary assessment, which is your ABCDEs, airway, breathing, circulation, disability, and exposure. A lot of what I talk about today will be found in your secondary exam, unless, of course, they have like an amputation or they're bleeding profusely. That'll jump up a little higher. But always start here and keep going back to this when you're out in the field. So pelvic traumas, these occur in about 3% of all skeletal injuries. Most of the patients are usually young, and it's a high mechanism of injury. So they're going to have a high injury severity score, and the mortality rates are pretty high. And I think we'll get into some of the anatomy. You'll see why. So the basic anatomy of the pelvis, the function of the pelvis is to bear weight. So it's bearing all the weight of your upper body and distributing it through your legs. It holds a bunch of organs. So as far as the bones, it's including the sacrum, which is in the back, and to me looks kind of like a dinosaur type fossil. Then you have your coccyx below that. Above the wings, you have the ilium, you have the ischium, and the pubis coming together, forming those smaller circles on the sides. Your acetabulum, which sits on the side and houses your femur, is comprised of 3 of those bones. So you have your ilium, your ischium, and your pubis. This picture right here, as you can see, there are 2 different sizes. This is representing the male and female pelvis. So the female pelvis is going to be wider for the purpose of birthing. The pubic arch, which you see on the bottom, is a little wider, and then the one up top is more acute. During childbirth, hormones are released, which allow that to actually stretch even more. It's pretty incredible. Most of the stability of the pelvis is through the ligaments, mainly the one up top at the pubic arch, so your pubic ligament right there, and then your sacroiliac ligaments in the back create a lot of the stability. And the purpose of this stability is to limit rotational force as well as vertical force. But you also have other things in here like your musculature, like your gluteal muscles in the back, your flexors and extensors of the hip. All those are so they're high energy impacts. You can have fall from height sports. A lot of what we see is going to be motor vehicle collisions, whether that's versus pedestrian, motorcyclist, or cyclist. Here's a picture I found of all the vasculature that's sitting right within the pelvis. Bleeding is the most common major complication and can occur mainly from veins about 80% of the time, and then arteries 20% of the time. If you fracture these bones, because there's bone marrow, you can have some bleeding there as well, but not nearly as much. So if you picture the pelvis, it's kind of like a round bowl, and so there's a volume there. And the problem with pelvic bleeding is that the bleeding will go into this pelvis and fill up this volume, and you really don't have any way to compress or stop it. If you look here, you have the aorta, which will branch down into the common iliac artery, and then the internal and external iliac artery, and it'll run down below the inguinal ligament, which will run right down through here. Whenever I go to feel a pulse on a patient, if I'm down, I just immediately reach down there and press as hard as I can. Depending on their body habitus, usually you're able to feel a pulse right there. So some of the classifications of pelvic fractures, there's 2 I was going to mention today. There's the simplified tile classification, which is based on the integrity. So your tile A up top are going to be your stable. That's going to be the invulsion fractures, or the minimally displaced, and the transverse fractures of the sacrum and coccyx. Your B's and C's in the simplified tile classification are going to be less stable and considered unstable. So you have your open books here in B1, and then you have your bucket handle fractures in B3. C1, C2, they'll have the bucket handle as well as the vertical shear. So if you can imagine, the pelvis is now moving vertically up and down. The second classification is the Young and Burgess. This is based on the mechanism of injury. To me, this is a little easier. So your anterior or posterior compression, so being hit from front to back. You got your type 1, type 2. Type 2 is going to be your open book. Type 3 is going to be your bucket handle. Type 1 in all of these categories are going to be your stable ones, and then the 2, 3s and the vertical shear at the bottom are going to be your unstable ones. Type 1 injuries, generally, when you go to press on them, they're not going to move too much. They're going to be pretty stable. They're going to resist some of that forming, mainly because this is maybe a bone fracture, and less so the ligaments that are still keeping it stable. Your 2s are going to be rotationally unstable. So if you were to grab their iliac spine and kind of push down, they're going to be able to rotate. And then your type 3s are both that and vertical shear. So they're going to have some movement up and down. As far as physical exam goes, I recognize that out in the field. Again, this is going to be found on the secondary assessment, but you do your primary. They're complaining of a lot of things. Maybe you're concerned about the mechanism. You can do exactly what he did right there, is which you grab the pelvis and you kind of rock it forward and back. I do not recommend doing it multiple times to be like, hey, I think this hurts. I think it's broke. You can do it once. And generally, when you do that, they're going to say, ow, if they're conscious, or you might feel some movement. I looked through a study which looked at the physical exam maneuver that he's doing right here and how accurate it is. They did it on cadavers. It's not sensitive or specific for unstable versus stable. So in other words, they couldn't tell just by moving, is it unstable or stable. The most reliable thing you can do in this situation is if they have pain. So if you grab their pelvis and you move it, they're in pain, then suspect a pelvic fracture, especially if you have a high suspicion based on mechanism. So again, hemodynamic instability is kind of the complication with pelvic fractures. So 10% of pelvic ring injuries will have hemodynamic instability, and these can occur if the pelvis is stable or unstable. So I kind of propose that, you know, you do your primary survey, you do your secondary survey, they say, ow. And now you think they're hemodynamically unstable by a shock index, which is heart rate over systolic blood pressure, real quick and easy. General rule of thumb for me is greater than 1. So if their heart rate's 135 and their systolic blood pressure is 135, I'm thinking they're unstable. So you've done all that, and the decision now is to place a pelvic binder. In my opinion, the pelvic binder placement should not delay transport. If you can do it quickly, great. If not, just keep them from moving too much. But essentially, a correctly placed pelvic binder is associated with a reduction in the transfusion requirements and their length of stay in the hospital. They proposed initially that it decreases the volume. So in other words, you now tighten up the pelvis. Well, they looked at cadavers again for this, and that might not be true. There's only minimal amount of volume reduction that you get. They actually think that you minimize the clot disruption. So essentially you stabilize the pelvis. It's not moving around as much, so the body has time to form clots and stop the bleeding on its own. Either way, it works. The study showed that there's about 50% that are appropriately positioned. And when I say that, they're supposed to be over the greater trochanter, so down, further down than you think. 39% were too high, above the iliac crest up top, and 11% were below. The problem with it being too high is that if you picture, I guess the best example is like a potato bag clip. If you put it too high, you're going to squeeze the top and you're going to open the bottom. And so that's the problem with it going too high. So if you're going to err, I would err too low. And one of the other things I read about that they proposed was that you can actually tie the feet together, and that'll also minimize movement in the hip and increase some of the stability. Sacral fractures are pretty uncommon. They usually result from high energy trauma. Only 5% in isolation, 45% with pelvic ring injuries. These are a problem because there's a lot of nerves that sit right behind them and go through them. So if you have a sacral injury, you're looking for cauda equina, the phylum terminalis, sacral plexus, sciatic nerve. This will cause sexual dysfunction, loss of bowel or bladder, or paresthesias. So these are the different sacral fractures. Zone 1 is going to be your sacral ala fractures. They're pretty stable. I'm pretty sure ortho doesn't do anything with that. Zone 2 is right through the neuroforamina. I think that's correct. Anyway, there's a lot of fragments associated with these, so these do have to be operated on, and these are associated with neurogenic bladder, so they're going to be urinating on themselves. And zone 3, the longitudinal and transverse are the highest risk for these neurological damages. I threw this picture in here because it took me a lot of time to figure out if he was jumping towards the ladder or if he was falling. And then I don't know what he has in his hand, but I picture this as someone that falls straight on their bottom and injures their sacrum. The acetabulum's, again, an interesting joint in the body because there's 3 bones that make this. You have your ilium, your ischium, and your pubis. I kind of just threw this in here. These are all the different types of fractures. At one point, I thought I was going to be an orthopedic, so I might have cared about this in a different lifetime, but ultimately, I'm just going to call my friends in orthopedics when they come to the emergency department. For you guys, they're going to have pain here. Stabilize them, keep them from moving, and get them in. That's all I was going to mention about this. So pelvic summary, again, you arrive on scene, trauma, do your primary assessment, you take a look at them, you're working through your secondary, their heart rate's high, they're hypotensive, and they have pain with your physical exam. So at this point, I would attempt to place a pelvic binder, tie their feet together, make sure it's above at the greater trochanters, and then transfer them. This is my little girlie. So I graduated med school from ETSU. Was lucky enough to become a resident here at UAB, which was by far one of the greatest things besides this that has happened in my life. But this is little Caroline. The picture on her left is her first outing. She's holding my drink there while I went to go to the bathroom. And the picture on the right, as you can see, I now have 2 women in my life that can tell me I'm wrong and tell me no. She can have whatever she wants at this point. She's awesome. All right, deep breath. We'll go through the upper extremity real quick. So we'll start up top. So your shoulder is comprised of the scapula, the clavicle, the acromion, and then your humerus. And then you go down a little bit, you have your radius ulna, the wrist, fingers. Some of the arteries that are going through your arm, you have your subclavian artery, which branches into the axillary artery, which is sitting anterior. And then that axillary artery becomes your brachial artery, and then your radial and ulnar artery down low. Nerves, which will come back to this, you have your axillary nerve up front, which does a lot of the sensation over the shoulder. Your musculocutaneous nerve, which is doing just sensation up top. Behind the humerus down here, you have your radius, and it's going to sit in a groove right behind that humerus, which will come up here in a second. Then you have your radian or your median and ulnar nerve down low. So shoulder dislocations, there's about 770,000 which presented to the emergency department between 2012 and 2021. It's very much age dependent on how these happen. So 0 to 20, likely sports, football, basketball, soccer, baseball is a little lower. And then if you get above 20, it's more likely to be home structures and construction materials falling off decks, things like that. The different types of shoulder dislocation. So there's anterior, posterior, and inferior dislocation. Your shoulder is the highest point in your body, so A comes first. So your anterior dislocations are your most common. Typically, these patients are abducted all the way up, externally rotated, and have some type of injury, which is going to push it out. Your posterior, these are kind of like the falls forward, shoot the shoulder back. They're going to be dislocated. When you have a seizing patient, they're more likely to have a posterior dislocation. I think it's because the deltoids are likely the strongest, deltoids and lats are the stronger muscles in the body. So they'll seize real tight, have those vigorous muscle contractions, and they're going to have your posterior dislocations. Your inferior dislocations are axial load. They're the least common, but they're most likely to have some of the nerve problems associated with this. And one of the nerve problems with this is that axillary artery, so they'll have some paresthesias over their shoulder. This is a picture. Again, you do your primary and then you do your secondary. I recommend getting clothes off if possible because you can see some of these things out in the field, but they'll have a prominent acromion, and then you'll see a deformity, and then you'll run your head over there and be like, that doesn't feel right. There's a step off right there. These patients won't want to move their arm. They might be able to move it with help if you grab them, but they're gonna hurt a little bit. So they'll be kind of tight to their body and trying to stabilize that. This is a picture of the inferior shoulder dislocation. So these patients are going to have their arm above their head because that's the most comfortable it is. If you grab their arm and pull it down, they're going to yell at you and try to shift it right back up. Very rare. And if you pull it down, it could go back in place and they could feel better. The humerus, so fractures of these represent about 4 to 6% of all fractures in young patients and 1 to 3% in the elderly. Again, high energy in the young and then falls in the old. Important point here is that if you have a mid-shaft humerus fracture, okay, again, I mentioned that radial nerve that runs right behind that groove, you're at risk to having an injury there. One of the things the radial nerve is responsible for is your power grip. So if you've ever noticed when you grip, one of the power moves is it'll go back a little bit, and that's that radial nerve kicking in. So it's power grip. They'll still have grip, but they won't have quite as strong as they would otherwise. This is a picture I found. They'll have bruising. You likely won't see this, I anticipate. This will probably be a couple days after their injury. Elbow dislocations following on outstretched hand, it'll shoot it back. Rarely do these have neurovascular injury, but the common ones is ulnar neuropraxia and brachial artery can be injured as well. Always check a pulse. Just check a pulse. Just let them know. Your forearm. of injuries which we worry about. I wanted to mention a couple, the Galeazzi and the Monteja. The way we remember the fracture patterns for us is Mugger. So your Monteja on the bottom is going to be a fracture of the ulna with anterior displacement of the radius, and then your Galeazzi is going to be radial fracture with displacement of that radial ulnar dislocation. The picture of the radius and ulna. If you ever get confused of which one's which, you can always, I used to have to do this for a while. You have to rotate. If you grab your wrist and you feel the bones, the bone that's rotating is the radius, and it's always at the thumb, and it's where your radial artery sits as well. These are the nerves and veins. This is the Monteja fracture, so you'll have ulnar fracture and anterior dislocation of that radius. These are severely unstable and they do require operation. And this is your Galeazzi, which is going to be your radial fracture, and then that radial ulnar joint disruption up top. Going down to the wrist, typically these are falls on outstretched hands. The scaphoid is the most commonly fractured carpal bone at 70%. The problem with this is that the blood supply for this scaphoid, and I'll show you a picture, goes distally and then comes back down the bone. So if you have a fracture there, you're at risk of avascular necrosis at one area of the bone. So it's very important to catch. I want to talk about perilunate dislocations, lunate dislocations, and Smith and Colley's as well. So this is the picture of the scaphoid. If you take your wrist and widen it out, you'll have this little dent that comes up above your thumb. This is called your anatomical snuff box, which is pretty funny. But right behind this is where your scaphoid sits. So if you're doing your secondary assessment, you're pressing around and you press right there and they hurt, maybe suspect a scaphoid fracture. One of the problems with these is that, or any small bones, is that if you get an initial plain film and x-ray, it might not show a fracture. So a lot of times these are followed up in a couple days to get another fracture to be seen. Because again, you're at risk for avascular necrosis in that proximal part closest to the radius. These are your lunate and perilunate dislocations. They're going to have a deformity when you see them. I wanted to bring these up because these are a pain in the butt to reduce. I've seen ortho have to take these to the OR multiple times just because they're so hard. Because ideally, you want all the bones sitting up top. Sometimes the lunate will spill out and everything else will be the same. And then sometimes everything else will move and then the lunate's in place. So you have your lunate and perilunate. Regardless, they're very hard to reduce and they will be deformed. These are your Colley's and Smith fractures, so fall on outstretched extended wrist versus outstretched flexed wrist. Your Colley's fractures are also called your dinner fork fractures. So the fall that radius bone is pushed forward and you kind of have a dinner fork. And then your Smith, so S is also your spade deformity. That radius goes down, so you're going to kind of have a divot before it goes forward. I wanted to mention this as a hand injury. So you get called on scene Friday night downtown, someone got mad and got in a fight and they're refusing transport. But you look and they have a little cut on their knuckle. I highly recommend you try to convince them to come in. I recognize they might not. The reason being is because you can get what's called fight bite. So our mouths are disgusting. There's a lot of bacteria. These patients need to come in for x-ray, washout, and antibiotics and hand follow-up because they're at risk for pretty bad infection and likely possibility of losing their hand. This is the most recent picture from Easter. This is me, my wife, and Caroline. I'm sure many of you have experienced what I had to there. We took no less than 13 billion pictures, both her mom and sister. Caroline was getting mad, throwing her bonnet away, and I was told there was no good pictures. And I'm convinced that this was one of the first ones, which was just fine. But just smile and get through it. That's all. Just smile and get through it. All right, lower extremity. We'll start with the femur. So the femur is comprised of your head, your neck, the greater trochanter over there, and then your shaft, and it goes all the way down. I wanted to mention the head and the neck portion first because the vasculature here is pretty important. You have your artery, the ligamentum teres, right here, and that's going through that acetabulum right there. And then you also have some collateral flow through the medial circumflex femoral artery. If any of these are disrupted, you're at risk for avascular necrosis of the hip, which isn't a good thing. They'll have to have a hip replacement. Here's some of the blood supply to the leg. So you have your external iliac artery, which will go into your femoral artery, and there's a lot of collateral flow from there, but it'll go down and become your popliteal artery down behind the knee. So femoral dislocations. So again, the hip consists of the acetabulum, the labrum, the joint capsule, the muscular support, and the surrounding ligaments. So again, up top, for dislocations, anterior A first is the most common up top at the shoulder. In the leg, because the anterior ligaments are the strongest, posterior dislocations are the most common. So A up top and then the P down low. Disruption of this joint can lead to avascular necrosis. So whenever you see a patient that has a shortened leg and you suspect hip fracture, they need to get in pretty quick because we need to reduce that. There's two different types, right? The posterior and the anterior. Typically, and I always have to do this by myself, but if you take your leg and you kind of raise it back in the hip, your foot's automatically going to kick inwards. So it's going to be internally rotated. So if they're shortened and internally rotated as you move back, I think posterior. If you kind of push forward a little bit, your leg is going to go externally. So that'll be your anterior dislocation. Again, all this matters because of the blood flow. So if the hip's out, you're not getting blood flow to some of those pivotal parts, and they're going to need a hip replacement. At one point, when I was making these slides and this presentation, I thought about adding a lot of sports, so I went down a lot of rabbit holes. But one of the things I thought was interesting was Bo Jackson. I tried to add the video, but they think this is what happened to him. So he's on a run down the sideline, and he was so strong, someone grabbed him by the leg, and he tried to pull out of it. And they think that when he did, he kind of disrupted some of that blood flow. A lot of doctors think maybe it was steroids, maybe it was just overuse, maybe it was idiopathic, and it was going to happen regardless. But there's one specific run that they think might have contributed to ending his career. All right, the knee. So the knee is comprised of the femur up top, the tibia and the fibula down low. You have your patella over top and your patella tendon, which will go down to the tibia. All kinds of ligaments, your LCL, your PCL, ACL, MCL, your cartilage, which is consists of your meniscus. A lot of things can go wrong here. In the back of the knee, just right in this popliteal fossa in the back is going to be your popliteal artery. That's one of the complications that you worry about with knee dislocations. So these are going to be high energy traumas. In order for this to happen, all kinds of ligaments have to be blown up. 40% of these patients that have the tibiofemoral disruption will have a vascular injury. You can also get peroneal nerve injury, which the peroneal nerve rides around the outside and is called your suitcase nerve, because if you've ever had a suitcase or something heavy and you've hit right there on your leg, your foot will go numb, it'll drop, things like that. Here's some imaging. So the dislocations describe the movement of the tibia compared to the femur. So the tibia goes backwards compared to the femur. It's going to be a posterior dislocation. The tibia goes forward in relation to the femur. It's going to be an anterior dislocation. This is a video of, well, I guess I restricted, but it was a video of a patella dislocation. Essentially, your kneecap will go to the side, whether medial laterally, most common laterally, but these patients will be a lot in pain. Their knee will be flexed up because that's the most comfortable. Essentially, what you have to do is you have to extend the leg and push it over. They're not going to like it, but as soon as the kneecap's back in place, their pain is resolved. So it's a pretty quick fix and no operation is needed. Call this the foreleg. I don't know if that's correct, but the foreleg consists of the tibia and the fibula. I wanted to mention this interosseous membrane, which sits in between, which is pretty important. You have multiple compartments in your lower leg. So you have your superficial posterior compartment, which is where your calf muscles are sitting. And then you have your anterior and lateral compartments, and as well as this deep posterior compartment, which is sitting right behind the interosseous membrane. So you have multiple compartments here, and these compartments are comprised of muscles, fascia, nerves, arteries, veins. The problem with this is that you're at a high risk for compartment syndrome. So this compartment syndrome happens whenever the pressure within the compartment becomes so great that you can no longer perfuse those muscles, nerves, or the capillaries. And so the capillary collapse, which are the smallest possible vessels in your body, the pressure essentially stops them from going. This is important because we have kind of time goals for compartment syndrome. So if you have 1 hour of compartment syndrome, you're going to have some nerve damage, which is probably reversible. Up to 4 hours, you start getting irreversible muscle damage. And then anything over 6 hours, you're at severe risk of losing your leg. For compartment syndrome, the most common site is the bottom of the leg because of those different compartments, which I mentioned previously, followed by the forearm, and then the thigh, and then the arm. You get your 6 Ps for compartment syndrome. They'll be in a lot of pain, pallor, paresthesias, poikilothermia, which is like hot and cold is altered, paralysis, and pulselessness. In order to fix this in the emergency department or up and medially, and you can see here how that's going to give more space to these compartments, because again, as long as you can create more space, that pressure is going to decrease and you're going to be able to perfuse those capillaries a little more. I wanted to talk too about hemorrhage control with extremity traumas. So the first step in hemorrhage control is going to be direct pressure with elevation of the limb, followed by wound packing. You can do the windlass technique, which is essentially you taking a sheet or a towel or something and tying it over the wound. You can do indirect pressure and then the use of a tourniquet. I recognize that out in y'all's situation out in the field, sometimes you have to use gestalt and jump from one place to the other, but this is the algorithm that you should go down. So let's talk about tourniquets a little bit. Tourniquets are used for significant hemorrhage from a limb that is resulting in hemorrhagic shock. The benefits should be that you're stopping the bleeding, and that benefit should exceed the risk that they have of losing their limb if the tourniquet's on too long. Placement of the tourniquet should be as distal as possible, but also 5 centimeters above the wound that you're worried about. It was interesting enough, through my studies, I always thought that you wound it up as tight as you could until they don't have a pulse distally. Well, in the studies I looked at, they're just interested in stopping the bleeding. So if you can stop the bleed and they still have a distal pulse, great, who cares, right? You've stopped the bleeding and maybe you still have some perfusion to some of those lower tissues. If the bleeding is not stopped by the first one and you wound it as tight as you can go, you can place a second one proximal to that or above it. It is important that anytime you reach for these tourniquets that you record your time. You know exactly when you placed it, because again, these hour marks are really, really important for their outcomes. If your transfer is less than an hour, you can leave it on. If it's greater than an hour, you can attempt to essentially take down the tourniquet and then replace it. A lot of times when you place the tourniquet, it gives the body time to clot off and kind of achieve hemostasis by its own. But you might be at risk to having to retighten it, which nothing's wrong with that. When you're placing the tourniquet, again, the lower leg has all these compartments and you also have 2 bones. So it's really hard to get enough pressure around everything to stop the bleeding. So you would like to go above the knee, which was my original thought, but going through it, if your goal is to stop the bleed and you can place it down there and you can stop the bleed, great. If you can't, just know you have to go above the knee and tighten it because you have 1 bone there and you can kind of squish everything around the bone. Same with the forearm. You'll have to go above the elbow, 1 bone, squish everything around the bone, stop the bleeding. Different type of tourniquets. This is the military emergency tourniquet. This comes apart. This one was interesting in the fact that you don't have to cinch it down all the way. You can just get it close and then start widening it and it'll tighten down. This is the one that I've seen most commonly is the combat application tourniquet. This one does have to be tightened all the way and then wound before you correctly have your tourniquet. This is your special operation forces tourniquet. This one was interesting in that there was a pin. I don't know, I haven't used one of these, but there's a pin that needs to be locked before you can tighten it. I haven't seen any of these. So that's at a disadvantage there. And so you'll clip it on and then you'll tighten it right there at that little circle. And then this is one of the newer ones. This is your emergency medical tourniquet. It's essentially a pneumatic, kind of like a blood pressure cuff. You'll place around and you'll pump it up. These are less likely to come deflated like your blood pressure cuffs are. Almost there. So this is the, I went through the website and looked at some of the anatomical criteria for trauma activations here in Alabama. I told Dr. Brown that I was going to do this, but so in order to be activated, you need 2 or more like some of my male friends might say, there's only 2 long bones in the body, the humerus and femur. One of the other things we have down here is the amputation needs to be proximal to the wrist or ankle. And then down at number 8, pelvic fractures, evidence of pelvic movement on exam. I don't know about this one, especially going through my studies, how we're not really going to be able to tell if they have movement there. I think it's pain, high level of suspicion, and a mechanism which matches. This was the guidelines for fractures and dislocations. I'm all for splinting any fracture or dislocation. Ultimately, you're creating a more comfortable environment for the patient, not having to move it around as much. This is kind of lowest on priority with these trauma patients. You're not going to cause any deformities or any loss of movement by not doing any splinting. Always check the pulses. And then I talked to a couple of the docs around about traction for femur fractures, and it seems like most people are on board with immobilizing is going to be quicker and more comfortable for the patient, and that way you don't have to fool with the traction pin. And you ask the question, well, what if they don't have a pulse? I think it's perfectly reasonable to try to pull. And if you get a pulse, great. You can actually put the immobilizer on and it'll likely keep that traction that you had to pull. But I wouldn't necessarily recommend getting out the traction device and pulling and delaying transport. And that's it. Any questions?
Hey, thank you for that, Dr. Kirby. Good lecture. So, had a little bit of discussion about knee dislocations. So, I think you showed a graphic that 40% were involved neurovascular disruption, primarily vascular disruption. Did I read that right?
Yeah.
So, but the patella dislocations really turns out not to be a big deal.
Right.
So, could you kind of give us some key points as to how to tell the difference in a pre-hospital setting without any imaging?
So they'll both have a deformity. I think that's based on physical exam. So if you take and palpate their knee, you'll feel even if they have a dislocation, they'll have their patella sitting there right above. If they have a posterior dislocation, you still might have a deformity there, but that patella is going to be midline and centered. If they have a patellar dislocation, that patella is going to be off, but the knee and the leg's going to be pretty centered, if that makes sense. Ultimately, I think you immobilize and transfer. I don't think there's much difference in care in the field.
So sometimes it seems like patients will report that they had a dislocation. For me, it's usually been knees, but then they say, oh, it went back in place because I hopped around and it went back in place. So how important is it for those patients to be evaluated at the hospital if it appears like function and pulses are restored?
I think if they had an actual dislocation of their knee, they're not going to be walking around and saying they're fine. So for those patients that think like their knee buckled and it hurt a little bit and they feel better now, they're not wanting to come in. I don't think they necessarily have to come in if they're not wanting to. Yeah, especially if they have capacity. Even if they did have a severe injury and they're refusing transport, have capacity then, as long as they understand the risk.
Very good. So we've got a lot of students listening, and for fractures or joint injuries where we can't find a distal pulse even before splinting, would that be a time, even if it causes some discomfort, to try to reduce the injury or just get them to the hospital, or contextual, use your best judgment?
I think as someone that works in the hospital, I would prefer them come to the hospital. I think it's perfectly reasonable to maybe try to give it one or two shots at getting reduced, but I don't think it should delay transport.
Yeah, I think that's fair. I think it kind of depends too on how long has it been going on, how long is it going to take us to get to the hospital, and those kind of operational factors as well.
I had a patient that had a shoulder dislocation that came in to talk to me. I get to talking to him and he's like, yeah, 3 weeks ago, I was putting in a light bulb and fell backwards and it came out. I'm not reducing that. It's 3 weeks old. That's going to be impossible to get in. I called orthopedics and they said the same thing. So timing of these things is very important. And there's a lot of things I won't even mess with.
Gotcha. We had a couple of people, every time we mention tourniquets, we have folks kind of ask the same questions. There's been a lot of teaching. I think TCCC still teaches, I may be wrong, if somebody has taken it recently, you can confirm or correct me, but teaches to always put tourniquets on extremities high and tight, no matter where on the extremity the bleed is. I think that's probably from a battlefield perspective. And I guess some of that could generalize to our work. But I kind of, my initial training years ago, we were taught 2 inches proximal to the bleed, just not over a joint. So if that works, there's no harm in having it lower. I guess my question is what's the big benefit in putting the tourniquet more distal, like below the knee or past the elbow?
Yeah, the main one hemostasis, then you're still perfusing your upper arm or your elbow. And I recognize that when you're out in the field, like you don't really have time to mess with, oh, I put it here, it's not working, let's move up a little bit, let's move up. And I think that's a lot of where the high and tight comes from, is you put it as high as you can and as tight as you can, and you're done with it. And to be honest with you, y'all got to use your discretion. I'm never going to fault you for that. I just want to tell you, like, if you can get it by putting it as low as possible, that's the best and most ideal. But if you have a lot going on and you're trying to control it quickly, high and tight, I think is reasonable.
I think the important thing there is that you may not get hemostasis if you put the tourniquet on the forearm, just because there's a lot of vessels that are deep. And so you may have a hard time actually compressing them if you put on the forearm. So that means you may need to do it above the elbow. If you can get hemostasis with it below the elbow, that's fine, but it may be difficult.
Yep. So something that came up, I think we've talked about it in EMS Challenge before. It actually came up in one of our classes not too long ago. So what about like a femur fracture that's obviously causing a lot of bleeding? You got a huge swelling thigh. You can actually kind of see it get bigger. And in the past, we've had EMS people put tourniquet on that injury, and they get both praise and condemnation from different folks for that. So I think the good teaching there for me, I always teach if it's not external, don't put a tourniquet on it. But what are your thoughts on that?
Yeah, imagine that, some controversial, different take. It couldn't happen here. I think I was there in that class. what do you do? There's one thought process is which you don't do anything because it's going to essentially clot off and compress itself. Because again, that pressure is going to build up. It's going to decrease all the blood flow. Or you could put a tourniquet high and tight and kind of stop the bleeding. Talking to Dr. Ferguson, I think he says go ahead and put on a tourniquet on. Just you can eliminate some factors and get them into us. So I'm okay with putting a tourniquet as long as it doesn't delay transport.
All right. So once again, it all boils down to risk versus benefit, thinking through the case and having discretion, making the best choices at the time. Yep. Very good. Great lecture. Any other questions from the room? We appreciate everybody participating today. Thanks to everybody who's attending online. If you haven't done so already, please fill out an attendance form for us. There's a link in the Q&A box if you're online. Also, here in just a minute, I'll be scrolling a PowerPoint that has a QR code you can scan to get to that. Or if none of that works for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link to the form. The password for the form today is ECMO, all lowercase, ECMO, ECMO. And thanks again, everybody. Thanks for the physicians for great lectures. Thanks for all the participation. Thanks for Birmingham Fire for hosting us today. And we'll see everybody next time.